Hey everyone, welcome back to the Optispan podcast. I'm Dr. Matt Kaberlein, and today I want to do something a little different before we get into the episode. I want to introduce you to Dr. Nicki Byrne, Optispan's Clinical Director. Now, if you've been following us for a while, you've probably seen Nicki on the channel before. You also know that everything we do at Optispan is built around one idea, that the best time to optimize your health is now, hopefully decades before the onset of chronic disease and disability. And to do that well, you need clinicians who actually live that philosophy, not just prescribe it. Dr. Byrne trained in molecular biology at Princeton, completed her internal medicine residency at Mount Sinai in New York City, and went on to spend years teaching medical students and residents at Northwestern. She's logged over a decade in clinical practice, and she has spent most of that time asking a question that doesn't get asked enough in traditional medicine. What if we treated people before they got sick? That question is exactly what brought her to Optispan, and it's the same question that drives every conversation you're going to hear her lead on this podcast. She's a runner, 2 marathons and counting. She prioritizes her own nutrition, her own fitness, her own longevity. She's not just talking about this stuff, she is living it. In this episode, Nicki sits down with Dr. Kim Brockenbrough. Dr. Brockenbrough is a board-certified cardiovascular radiologist based in Seattle and the CEO and founder of CardiaVision LLC, a specialty practice focused on advanced heart imaging and preventive cardiovascular diagnostics. This is an eye-opening conversation about coronary CT angiography, why a 0 calcium score doesn't mean you're in the clear, and what soft plaque actually tells us about cardiovascular risk, and why Dr. Byrne is now sending a significant number of her patients for coronary CT angiograms. It's a great episode, and it's just the first of many from Nicki on the channel. Enjoy the episode.
Just a month or two ago, I had a patient, 48-year-old runner, runs like 10 to 20 miles on the weekends, 20 minutes of cardio a day, had an 80% stenosis of his left anterior descending coronary artery, just from soft plaque with a 0 calcium score. So the soft plaque scares me, and we miss that with the calcium score.
When I think of different populations where the calcium score might give someone a false sense of security, I think of women, younger patients, diabetics. Are there other populations that you would be more worried about?
I worry about everybody. Based on history, we don't know exactly what's going on. We see soft plaque all the time, so little bits can break off and go to the smaller, more distal vessels and cause congestive heart failure or dementia. So a stress test is only going to be positive when there's a 70% narrowing of the vessel. I think you should treat coronary artery disease 20 years before that.
At what age should patients start doing CCTAs if they're asymptomatic? Hi, I'm Dr. Nicki Byrne. I'm the clinical director here at Optispan, and I'm welcomed on the podcast by Dr. Kim Brockenbrough from CardiaVision.
Thank you, Dr. Byrne.
So why don't you tell our audience a little bit about who you are and your background?
So I am a board-certified radiologist. I have been looking at blood vessels with a CT scanner for over 25 years. Started with a 4 detector, started looking at the vessels in the neck with the 4 detector, started looking at the renal arteries for renal artery transplants, did some looking at the hepatic arteries for hepatic living-related liver donors, did runoffs for legs, worked with vascular surgeons, and now predominantly looking at the vessels of the heart for cardiovascular disease.
Okay, and you're the CEO of CardiaVision. Do you want to tell a little bit about what CardiaVision does?
So we look at the coronary arteries with a CT scanner before a heart attack or sudden death. So this is a preventative option and much better to treat it 20 or 30 years before a heart attack rather than in the midst of a heart attack.
Okay, that was a good segue into my first question. Before we dive into any of the specifics, when you think about cardiovascular disease through a longevity lens, how do you think about imaging as compared to labs or the 10-year risk calculators or even functional tests like a VO2 max?
So I'm a radiologist. I believe in pictures. I think blood levels are leading and lagging indicators of disease. The picture shows what's going on. What we want to know is how much soft plaque you have and how much calcified plaque you have. The calcium score will only show the calcified plaque, which is kind of end-stage disease, and the soft plaque is seen on a coronary CT angiogram, and that shows earlier disease, and that soft plaque is more likely to rupture. So maybe I'm getting a little ahead of us.
Yes, well, that's a great segue into why don't you kind of describe the life cycle of plaque and how it is formed, and then what tests you can see different levels of plaque at?
Well, I've got a picture that my daughter drew. And I show this to every patient that comes in for a coronary CT angiogram. So basically I start really basic with every patient and kind of apologize, but say, okay, your heart is your pump and your blood vessels are your pipes, and junk in your pipes is atherosclerosis. It's plumbing. It's super important plumbing, but it's plumbing. So then for this picture, we get down to those pipes. And so the first frame is a normal artery. And the second frame is fatty plaque, and then fibrous plaque. And the last frame there shows two different things. One is the calcified plaque up on top, and the lower part is rupture of the plaque, which is a heart attack. And when that happens in the brain, it's a stroke. Now, that soft plaque that we see before the calcified plaque is more likely to rupture. And that was shown in the SCOT-HEART trial of 2020. And so just because you may not have calcified plaque, you might have soft plaque, and that is more dangerous than the calcified plaque.
Okay. And when we're talking about these different types of plaque, can you tell us, how coronary calcium scores are used in treatment? And then where do you see the benefit from the coronary CT angio?
So a calcium score often in the healthcare system is used to determine if somebody should go on a statin. So the 2018 guidelines, I think, say that if you have a calcium score of even 1, it's recommended to go on a statin medication. Okay, great. The issue is we looked at the first 100 patients of 2024, our patients, and of those who had 0 calcium scores, 70%, that's like 69.8%, had non-calcified plaque. Just a month or two ago, I had a patient, 48-year-old runner, runs like 10 to 20 miles on the weekends, 20 minutes of cardio a day, had an 80% stenosis of his left anterior descending coronary arteries just from soft plaque with a 0 calcium score. So the soft plaque scares me, and we miss that with the calcium score. So the only way to see soft plaque with a CT scan is to give contrast. You can also see soft plaque if somebody takes a catheter, puts it in your heart, and uses an intravascular ultrasound, but it's way more invasive than a CT scan.
Yeah, and when I think of different populations where the calcium score might give someone a false sense of security, I think of women, younger patients, diabetics, or those with insulin resistance, and inflammatory phenotypes. Are there other populations that you would be more worried about even if they had a negative calcium score?
I worry about everybody. I just don't. Based on history, we don't know exactly what's going on. The 48-year-old runner, we thought he'd be clean. I just had a patient, he's in his 50s, a calcium score of 1, had 90% stenosis of his left circ and his first obtuse marginal branch. Just a calcium score of 1, so you think it's nothing, and he may need stents. Now, he's not having chest pain. So I just think it's mainly a function of price. And the coronary CTA involves a lot more, it's just much, much more intensive. And so it costs more. And the calcium score is done by almost every imaging center. It's very accessible, and it's sort of better than nothing. And then the other limitation of a calcium score is that if you're on statins, the statin melts and calcifies the soft plaque. And so your calcium score should go up, and the coronary and the soft plaque goes down. So it's sort of better than nothing, but it doesn't give you the full picture.
And are there specific questions that a CCTA can answer better clinically for you?
Well, the amount of stenosis, the amount of soft plaque. You know, if you got a little bit of soft plaque, do you want to be super aggressive with therapy? Maybe not. Would you want to try some lifestyle things? Possibly. If you have a 90% stenosis and a calcium score of 1, you do not want to play around. You want to be aggressive with medications and, you know, possibly an intervention.
And with a CCTA, are there different characteristics of plaque that you could see besides just soft plaque? Can you tell if something is more high risk?
I'm pretty binary with it. I mean, it's either soft or calcified. I know that the AI claims to, or the AI software claims to be able to tell the difference. I'm not sure that's super accurate. I mean, you have a voxel of, with information in it, and you can get partial volume averaging in there. So I think we're not at the histology level with a CT scanner. So I just soft and calcified, or soft and harder. Yeah.
One question that we get asked often is about timing. So in an asymptomatic patient, when would you recommend that they get a CCTA?
Yeah. So if there are any risk factors such as high cholesterol, diabetes, family history, we recommend a coronary CTA for men in their 40s and women in their 50s, and then 10 years older if there are no risk factors.
And my understanding is the CCTA lets us follow changes in non-calcified plaque over time. And so if we did a scan on someone and started them on therapy, is there a time that we would follow up with another scan?
Yeah, I used to say a year, and really the literature is sort of looking at 2 years. And I think it depends on how severe. If they have a lot of disease, I would say 1 to 2 years. We don't have data to support 1 versus 2. And then if there's minimal disease, I'd say 3 to 5 years. I am in favor of doing a higher dose CT scan. A lot of people are advocating the low dose CT scan. But I think in order to see the shades of gray, which is the soft plaque, you need a higher dose of radiation. And so I believe in a little bit higher dose, roughly equivalent to living in Denver for 1 year. So it's not that much. But I also don't want to scan patients every 6 months or, without much disease. So I don't want to do it that frequently. But when I do it, I want to do a really good job with it.
And you brought up the question of radiation. Are there any other risks to getting a CCTA?
Contrast has its risks. Very, very low risk of a reaction to the contrast material. Some risk in patients that have kidney issues, which may or may not be true, but we still check for that.
And there's some new protocols now that are recommending CCTAs for patients with stable chest pain, for low to intermediate. Can you speak to the differences between the results you get on a CCTA and those from a stress test and how that's clinically useful?
Yeah. That's a great question. So a stress test is only going to be positive when there's a 70% narrowing of the vessel. We see soft, and I think you should treat coronary artery disease 20 years before that. And so a coronary CT angiogram, we see mild, less than 25% narrowing of vessels. And, so we see it much sooner than a stress test. A stress test is a really low bar of health. It essentially kind of means you shouldn't be considered for a stent if your stress test is positive. That's a pretty low bar of health.
And one thing that surprises many clinicians is seeing a high plaque burden on a patient who's had a negative stress test. How common is that? And does that tell you anything about how coronary disease progresses?
Yeah, I see. I mean, we see soft plaque all the time. And some people have a lot of non-calcified plaque that isn't at a 70% narrowing. And the issue is, yes, that can occlude a vessel, but also the soft plaque, if it's not flow limiting, can also be problematic. And I think it's one of two things go on. One, you can get small emboli, so little bits can break off and go to the smaller, more distal vessels and cause congestive heart failure or dementia. I think also what we're seeing in those 3 millimeter vessels, the coronary arteries, may also be a sign of more distal disease that's not necessarily embolic, but disease in the sub-millimeter vessels. And again, leads to dementia and congestive heart failure. So in my estimation of things, like clean vessels is good for longevity. So waiting until the stress test is positive is just a super late point. Now, it doesn't mean that the medications will still work. It will still reduce plaque. So that the patient that had the 80% stenosis, I sent him to, he went to an interventional cardiologist. They did not stent him because he's not having chest pain. And the medications are going to work like Drano, and they're going to clean that up.
Yeah, tell me a little bit about that. So which medications help, arrest progression of disease or regression?
I think it's regression. And there's a trial called the LOCATE trial, a smaller study done in Germany in 2024 shows that a little bit of statin will melt the soft plaque a little bit, and a high dose will eliminate it. Same with the PCSK9 inhibitors like Repatha. It will eliminate the soft plaque. And we see this in our practice. We're seeing, 2 different scans at, a year to 2 years in time with regression of the soft plaque and then increase in the calcified plaque.
Yeah, I'm glad you brought up the LOCATE trial, because one of the things that it also shows is that there is a strong association with decreasing LDL. And so when you look at that, the lower you get the LDL, the more regression that you get. And so I think for a lot of people who may have heard on social media that higher total cholesterol might extend longevity, there's been a recent plug on that. There's, more clear data that shows when we drive that LDL number down, especially in patients who have coronary artery disease, that we're going to see that improve.
Sure.
Now, is there any difference in your mind with a high intensity statin or a PCSK9 inhibitor?
I think the problem with the high dose statins is people don't tolerate them well. I mean, some people do. And I get people and they're like, oh, I've been on a high dose statin and all I see is calcified plaque. They've been on it for 5 years. All I see is calcified plaque. Great, stay on it. It's working for you. I think just the Repatha doesn't have the side effects and it melts it as well. And now it's gone down in price. So it's down 60% in price. So it's $239 a month. And that's, I think that's the water of the fountain of youth. I mean, I think that's good stuff. And statins are great too. They work really well. It's just, if you have pain, nobody wants to be in pain. Like what I like to say to our patients is, we want you to live to be 100 and happy you're 100. If you're in pain,
Yeah, at Optispan, we're thinking about the PCSK9 inhibitors pretty quickly in patients who, we can't get their ApoB and their LDL numbers to target, which is pretty often. But I'm also thinking about them immediately in patients who have, a really high Lp(a) or an ApoE4 allele or really significant coronary disease, and they've been on these high doses of statins for a year. Any thoughts on which patients that you would, when you see them in your clinic, would talk about a PCSK9 inhibitor?
So I'm a radiologist.
I know.
I don't know all the blood levels to the degree you do. I just see people do really well on PCSK9 inhibitors. And some of our docs are using a little bit of statin and then PCSK9 inhibitor, and it just is really good stuff.
In your practice, do you see more regression in patients on statins versus PCSK9 inhibitors?
I see more regression with PCSK9 inhibitors, but I see people not at max dose statins. Because I think a lot of primary care, titrate the statin to the symptoms. And so, which is super reasonable. You don't want to put your patient in pain, but I don't think that's the proper way to titrate statins. I think it's max dose. Now, am I proved wrong? Of course. This is kind of what the data shows. We see some athletes. I've had 2 athletes in the past month. So, okay, my N is 2. I'm not trying, but 2 pretty hardcore athletes. They had calcified plaque, but very little non-calcified plaque. And so it's does lifestyle, do we have these? We don't have a trial showing coronary CTA before in a super athlete, coronary CTA after, and they have less soft plaque. But I think that's a function as well. But I don't think it's like 3 miles once a week. I think it's like, but I don't, you know what I mean? Like, I don't know, but I think there's something to exercise, but we don't have the long-term data. The drug companies do the big data that, they're the ones that fund those trials. It doesn't mean other things don't work.
Yeah. And, a lot of our patients can be alarmed when they look at their calcium score. So even if they get a CCTA, they get a calcium score with it, especially if they're on a statin, and they'll say, why did my calcium score go up? Can you speak to how statins affect the calcium score and whether that increase actually has a meaningful effect on patients' vulnerability?
Going up is exactly what you want to see. I've seen people with calcium scores of 2,000 or 3,000 and don't see much soft plaque, and they've been on high-dose statins, and I'm like, good, you're making a lot of atherosclerosis in your coronary arteries. Like, that's just genetic makeup, whatever, like the patient's making a lot of atherosclerosis. And then it's getting treated, and then the scar, or sometimes I like to think of it like a stent, a strut of a stent maybe. I don't know if the calcium's beneficial or not, but it's certainly better than the soft plaque. We want their calcium score to go up. So I explain that to every patient.
Now let's talk about some AI-based tools. So there's a lot of talk about these plaque quantification tools. Mm-hmm. In your experience, have they meaningfully improved risk stratification? Do you find that they are changing management or changing radiology reads?
It's interesting software. As a radiologist, I see the same soft plaque the software sees, and I quantify it as mild, moderate, severe. They are able to give a number to that. How we validate that number, I don't know. AI is validating itself. I don't know. I can't validate their numbers. So that brings concern to me. I think also the ability to compare is really tricky. And one, coronary CTA on the same patient, same scanner, may have a different heart rate, may have a different phase of the contrast. It's not same apple to same apple comparison. And so sure, you're going to get a number for one, and yes, you're going to get a number for another. So what I do is I look at the most worrisome plaque and then go, okay, or all the plaques, but you focus on most worrisome to most worrisome. And then you go, okay, is that more or less soft plaque, more or less calcified plaque? And usually it's less soft plaque and more calcified plaque. And so its ability to compare, I think software I don't know if the software is able to do that well. As far as management, I think a well-trained cardiovascular radiologist, can do that quite well. So we don't incorporate that as part of our program. I know some of our referring clinicians do, and they use that maybe more than, and I don't use that just because I don't see it. And I'm not the one managing the disease. You guys are managing the disease. So you guys are collecting all the data, and there's so much data to collect. I'm looking at the images and basing what I have, my opinion, solely on the images, not everything else. And so that's more data for you.
It is more data for us. And I've had a couple patients, some with you and some with other clinics, where these AI quantification tools have come up with a different read. You have been kind enough to relook at the images. Have there been a time where a physician came to you and said, I have this different read from the AI software? Do you agree or disagree with it that it's actually changed your read?
I had one that it said there was a high-grade stenosis, but we had cut off the artery. So it was a technical error. We brought the patient back, but we already knew to bring the patient back. And they're saying it's a high-grade stenosis, but it wasn't. It was a technical error. And that's pretty typical of AI, to know what perfect images look like and not necessarily be able to interpret artifacts that happen. And so that one, we brought the patient back, but we knew. I don't recall of any that it showed me something that I didn't already know, but it doesn't mean I'm perfect.
Yeah. As these tools get better over time, which they certainly will,
Sure.
Where do you see a role for this type of software?
Oh, I think there's a role for it, especially, for people who like numbers. I just would be concerned about the validation of those numbers. I think, it's available for lots of people. It's widely available wherever you get your coronary CT angiogram. It's going to be available. So I think it's interesting. I just saw somebody posted on social media about FFR-CT being not charged and then the patient got charged. And it's like FFR-CT is not needed unless you have a moderate to high grade stenosis. And so most of the patients we see don't have that. So you certainly don't want to pay for FFR-CT if you don't have a stenosis. And that was sort of created back in the day where 70% stenosis meant stent. And now that is not the clinical practice. I mean, the ischemia trial showed statins, stents, and bypass all prolong life the same if the patient's asymptomatic. And so, okay, your FFR-CT shows flow limiting. Are you going to stent it? Because if the patient doesn't have symptoms? So it's a lot of information, and I'm not sure all of it's necessary, and I can't validate it. So that makes me nervous.
Yeah, with these ischemia results that you can get from the AI software, has that been shown to be accurate as compared to when you're doing it through a cardiac catheterization?
The data on it looks pretty good. My experience with it hasn't been as good. And so I don't trust it. And maybe, I'm sure someday it'll be great. But again, even if there's ischemia and the patient doesn't have chest pain, most people aren't going to do, I don't know, that's a cardiology thing. And I'm happy to, we provide the images for the AI. If clinicians want them, their patients want them, we're happy to provide that. It's just not our standard practice.
Talking about the future, where do you see cardiac imaging playing a role in clinical practice?
I think what I have seen is more and more people are interested in doing coronary CTA throughout the country. So I think those imaging centers are going to increase. And I think it's a good thing knowing if you have coronary artery disease 10 to 20 years before a heart attack or sudden death is really important information. I think it's the holy grail of longevity, just knowing what those vessels look like. A CIMT is really good to look at the carotid. So you look at the heart, you look at the brain. I wouldn't do one or the other because you want to know if both are okay, especially if there's a family history of heart disease. Heart should be first. If there's a family history of stroke, carotids should be first. We could look at the carotids with a CT scan, but you can feel them. You can do it with ultrasound. You can look at the thickness and see if there's atherosclerosis there. So I think it should be kind of, with risk factors, all men at 40 and all women at 50, 10 years older without risk factors. So I think it should be universal, and I think more people are starting to agree with me.
Yeah, I mean, I'm definitely a convert. I send tons of my patients now for CCTAs after I've seen the benefit of getting that information back and how powerful it is for the patient to actually see that there's disease in the artery. So we're not just treating a number, we're actually treating disease, which I think makes people a lot more compliant with their medications, a lot more willing to make change in their lifestyle, which, at Optispan, we think that's the biggest lever you can do. So I find so much value in the CCTA. So Dr. Brockenbrough, can you tell me a little bit about the patient experience going through a CCTA and any medications they might be asked to take ahead of time and why?
Sure. Yeah. We look at the patient's resting heart rate, and they may or may not need beta blocker or verapamil just to lower the heart rate. We like it nice and low. And then the patient gets on the scanner and we do a calcium score just to see where things are there. It's worth something. So we do the calcium score. Then we give the patient nitroglycerin to dilate up the blood vessels, and we get a better look at the blood vessels. Then they get scanned. We give them contrast and they get scanned. And then they review the images with me. And so we go through their history and their images, and they get to see the images as soon as they're off the table. So patients like that, we get really pretty good feedback about that. And we get a lot of patients that are like, I'm not doing statin. There's no way. I don't like medications. And so we kind of review that. And what's nice now is Repatha, because it's gone down in price so much. Before it was like, okay, you go to this person and then this person, and they might be able to convince your insurance company to pay for it. Now it's like, just go to GoodRx and start Repatha. So I think I get why people don't want to do statins. I think they also work really well, but nobody wants to be in pain that long. So having that conversation with patients is really good. And even the ones that didn't want to go on statins, a lot of time when they see the soft plaque are like, okay, I get it.
And don't you have 2 furry employees that sometimes accompany you?
I do. There's Winston and Summer. And they're my golden retrievers, and they are a big hit on social media. People are way more interested in them than me. And so they're lovely. They're service dogs who treat anxiety. Not every patient sees them, but generally people that get bad news, I usually say, especially if people are upset, I'll say, okay, do you want a big dog or a little dog, or do you want both? Because the puppy's now almost a year, but she's been growing quite a bit. So yes, I have 2 furry employees.
Yeah.
And they are lovely. They're in the car right now. But yeah, they're lovely.
And I've seen pictures of them. Neither look small.
Oh, I guess small is right. They're golden retrievers. Yes.
So longevity medicine often talks about optimizing risk factors decades in advance, and traditional medicine is usually quite a bit later. Where do you see coronary calcium scores and CCTAs kind of bridging that gap?
I just think it's way before symptoms. When I was in the healthcare system doing, starting coronary CTA programs, it was for patients who were in the ER, possibly having a heart attack. Like, that's super late. There was actually a longevity doctor I met at the recent meeting in Las Vegas. I just met him in November. I think that meeting was in November. Super nice guy, learning about longevity, doing a lot with his health. He was liking my post, and we were, kind of communicating versus social media. I saw a post the other day that he's 47. Passed away of a heart attack. And so it's like, I just, I wish he had a coronary CT angiogram. The patient with a 1 calcium score and 90% stenoses. So I think this stuff can be treated so much earlier. I think if you need a stent or bypass surgery, really, really late in the game. I just think this is really an incredible way to do longevity. And of course, you go to these meetings and there's some snake oil out there. This is not snake oil. This is a real test with excellent science behind it, and should be done with anybody who's, within those parameters.
Yeah. And I'll add, not only is there excellent science behind it, but there's, treatment algorithms too.
Exactly. And you don't lose your hair. It's not like chemo and you lose your hair. Like, the medications work like Drano, and probably some lifestyle things work too. We just don't have the data on that. But there's ways to melt that soft plaque. And so I think anybody who has it should be melting it. And you got to know. That
patient that you described, I think, is really good for describing what traditional medicine looks at. So they define success in this realm as preventing a heart attack or fixing ischemia. So, putting in stents, doing bypass. But here at Optispan, really focus on optimizing longevity in terms of health span, like keeping people functional. Where do you see cardiac imaging playing a role there?
A friend I know had his father died suddenly in his 50s of a heart attack. He's been on statins forever, and he's in his 90s cooking people dinner. So it just works. And you have to know you have disease, and then you can treat it, and it works. And there's so many things on the horizon. There's PCSK9 inhibitors that you take by mouth, and you don't need to give yourself a shot. There's PCSK9 gene, so taking out that gene that causes it. There's lipoprotein little a medications that target that. So the future is really bright. And I like to tell people, our patients, that our goal is for you to live to be 100 and happy you're 100. You don't want to be in pain. You don't want to be demented. And that's what you guys do, is keep people happy and healthy before they're in and out of the hospital.
That's a great summary of Optispan. And then, is there anything else that we didn't cover that you think is really important for the audience to know? Either about the coronary calcium scores, progression of plaque, your dogs?
I think testosterone's interesting. The Traverse trial is a 2-year trial. I've got it here. So a 2-year outcomes trial, pretty short. And it showed, no significant outcomes in patients that were on testosterone or not testosterone, no adverse cardiac events over 2 years. So that's a really short period of time. The other thing is what's kind of cool about it. And I don't usually tell people don't be on testosterone, because we do know from the TOM trial. So the TOM trial showed, was stopped early. It was in 2010, and it showed testosterone in older men looking at their mobility. And it was stopped early because people had, the vets, the older gentlemen had cardiac events. So it was stopped. And so then everyone said testosterone's awful. Okay, so now the pendulum swung to testosterone's great. It makes people feel great. Men, women, it makes people feel great. But what's interesting about the Traverse trial is that 84% of these people were on lipid-lowering therapy. So, and then their LDL cholesterol was 80, 79, and 80. So they're being very well treated for cardiovascular disease. So great. Enjoy testosterone. I don't know if it's good or bad, but make sure if you've got coronary artery disease to treat it. And so you get the coronary CTA, and then if you've got it, and then you treat it. So I think it's important to be, the pendulum is kind of swinging, and I think we just need to know, if you have coronary artery disease and you want to do hormone therapy, let's just know about it, and then you can treat it. So many things cause coronary artery disease. High sugar. I've got a little bit, high sugar. So I say, oh yeah, if you eat more protein, that's good, right? I have a sweet tooth. I'm from the Midwest. I'm a pretty good pie baker. Like, if you told me no more sugar, just kale, I'd be like, I'm going to die sooner. I mean, I think that's the same way people are with testosterone. Great. Just know if you have atherosclerosis. My coronaries look really clean. So I'll eat that sometimes, not all the time. So I think it's just knowing gum disease can cause coronary artery disease. So just know it. Treat your gums. So there's a ton of things. We used to say, when I was in med school, it was like, it's just cholesterol. And now, of course, we know it's inflammation too. And so many things cause inflammation. So I think just being aware of what's going on in your coronaries just can give so much insight into what you do with the rest of your life.
Yeah, and I think that's a really good point about the testosterone is, we're checking almost all of our patients anyways with the CCTA if they have risk factors. And honestly, almost everyone has risk factors, right?
Yeah.
And so you're going to get a CCTA. And if you're starting testosterone, you'll at least know, do you have disease in the arteries? And then, as we spoke about before, we can start treatment and we can repeat another scan in a couple years and see, is our treatment working, or is the testosterone giving us an uphill battle or not?
Right. Exactly. Yeah. I mean, I saw somebody the other day who was on testosterone for a while, didn't have much soft plaque. Great. If you got an 80 to 90% stenosis, I'd probably cut back on that. So it's just knowing and having information to know. And I think the blood tests are leading and lagging indicators. And so the coronary CT angiogram shows you exactly what's going on at the time of the scan.
Did you want to talk about any of these images?
This is an interesting patient. So what we have here are less than 1 millimeter slices through the chest of a coronary CT angiogram. And you can tell it's a coronary CT angiogram and not a calcium score because there's contrast. And so I see the contrast. It's in the ascending aorta, which is that circular structure kind of right in the center. And then there's a little line coming off, and then there's a bump of soft plaque. And that's in the left main coronary artery. And then there's some brighter stuff, and that's the calcified plaque. And this nicely shows what what statins do. It peripherally calcifies, but it didn't completely melt the soft plaque in the left anterior descending. So what happened, the patient was on kind of a low to moderate dose of statin. Clearly, you don't want soft plaque in the left main. So I talked with the clinician, and we talked about doubling the dose of the statin on this patient. But it's nice that it shows those peripheral calcifications, and it really kind of, the vessel is, that left anterior descending is really wide open. You have to go through the images and see the full vessel. But that's what is kind of nicely shown in this image.
You want to talk about that one?
Yeah. So this is the difference between a calcium score and a coronary CT angiogram. This is the same patient. So the first image shows, you can see that bright white, which is the calcium in the left anterior descending, but there's no contrast, so you can't see the soft plaque. Then we do the coronary CT angiogram showing that soft plaque and showing it with the contrast. And it also shows that there's a little bit of soft plaque right next to that calcified plaque. And this gentleman is in his 40s, and I think a couple years prior, his calcium score was 0. So he's since calcified some of that soft plaque, and then he still has soft plaque. So we want to treat that. And that just shows the difference of what you see in a calcium score versus a coronary CT angiogram.
Well, Dr. Brockenbrough, it has been so much fun having you on the podcast today. Before we go, do you want to let everyone know where they can find you?
You can find us on Instagram, where we're doing education with the dogs, at KimBroMD. We're on LinkedIn at Kimberly Brockenbrough MD. And CardiaVision, we have a LinkedIn site. And then our website is cardiavision.com. And if you come and get a coronary CTA, we're in Bellevue, down the street from Overlake Hospital.
And do patients need to have an order from their physician to come see you?
No, they don't.
Okay. Well, thank you so much for coming on today, and we'll talk soon.
Thanks, Dr. Byrne.